Hello all, thank you for tuning in. So today we're going to be talking about the placement of a stabilization system that is used when patients are not candidates for a gel fix or for a percudine. Now it's very important to note that this is also a minimally invasive system that only has a posterior approach. So the patient is only addressed from the back side, not from the side or from the front. We usually try to avoid this as much as possible. Now, when is the NEO system used in surgical settings? Usually when a patient is diagnosed with either Anterolisthesis, okay, a forward slipping, let's call this L4 and L5 for argument's sake. When L4 slips forward, we call it Anterolisthesis. If there is a posterior slipping, this is going to be called Retrolisthesis. This is a little less common. We mostly see a lot of patients that come to us with Anterolisthesis because this makes the foramen a lot smaller, making the nerve root more compressible. It also makes the facet joints worn out much quicker, which causes facet joint arthritis. And so the patient comes to us with a combination of systems, but at the end of the day, we have to stop this forward shifting from L4 on L5. So how do we do this in a minimally invasive setting? So in order to perform this in a minimally invasive way, let's take this model spine here, which already has 1, 2, 3, 4 holes drilled into it. So again, let's continue with the L4, L5 kind of scenario here. So in this setting, what happens is that the patient is facing downward, and what we do is we're going to use some guides to make sure that we are headed in the right direction. We advance the screw in this way, and while checking with the fluoroscopy guided system to make sure we're going into the correct direction. And the screw ends up in this manner, okay, in this plane. Sort of like this. And then on the bottom, it would look basically just like at the top. Now, after we have 4 screws placed, 2 on L4, 2 on L5, we basically, they would be in this set in this manner. So in green, you have the screw, which it has a good grasp on bone. Here we see a bridge. You can kind of see it within the delivery system. The white is the delivery system alone, okay? And we only use it to deliver the screw. It doesn't stay in the body, obviously. So once the 2 screws are in place, we place a stabilization rod that looks sort of like this. And then this is going to prevent L4 from further moving forward so that it's now in a more anatomical position. As you can see, the rod has some lordosis to mimic the anatomical position of the human body. Now, what stabilizes the rod, you may ask yourself? Well, what we do is after the rod is in the body, we take a cap, which is in the tip of this delivery system. We place it in this manner, and we start screwing downward so that the cap, once it reaches this point, is going to hold the rod down in place. Now, after all is said and done, you're basically going to have 2 screws here, 2 screws here that are going to go into the bone and that are going to stabilize L4 and L5. By this point, we would have already done a complete decompression on this segment, clearing the foramina, the ligamentum flavum, which is the yellow ligament, which is on the inside, and any other calcified ligaments or soft tissue that are preventing the nerve roots from exerting their normal action, and so that they're not eliciting pain anymore. So thank you for tuning in. This is the system in a nutshell. If you would like a further clarification, we can always do a video consultation. And these are offered to you at no cost. And you will see our contact information after the video is over so that you can hopefully reach out to us and we can hopefully consider your case. Have a great day.